Jenny, what has your been experience with the hyperopic utilization of the light adjustable lenses, and sort of your experience in terms of patient satisfaction with both distance as well as near?
We've had outstanding outcomes with hyperopic patients where I know I've seen in the past any other lens, you oftentimes see regression or just not even getting the correct power in the lens, and patients are unhappy. With the light adjusting lens, we can wait until everything's stable and adjust it. And we're getting patients down to 2015 and stable we have some that are 3, 4 years out now, still no regression and very happy, being able to see distance, intermediate, and near.
So what about, with hyperopia and the LAL, how do you deal with patients who are pre-presbyopic, Jenny? I mean, that's kind of a challenging discussion. Somebody who's in their 30s, let's say, and, LASIK is not an option. ICL obviously is -3 or more myopic, and so that's not an option. For patients who are pre-presbyopic, how do you talk about that? How do you address that?
A lot of them already, I feel like, are struggling to see up close, so they know. A lot of my patients in their 30s are already using some type of reader, so they're already struggling at that point. I just let them know once you have this lens implanted, there's going to be at least 2 to 3 weeks where reading is going to be difficult. You're going to need a higher power reader temporarily, but then we are going to adjust the lenses and you're going to be able to see all of your functional needs, like your phone, computer, and everything fine with that.
Do you take multiple times? I mean, so personally, when I have somebody who's coming in and they're hyperopic, and let's say there's one patient in particular that I'm thinking of. We did a 29-year-old girl. She was +8 with 2 diopters of cylinder, and she was a news anchor. And so she's in the public eye. And so we obviously want to make sure she's very happy. So she's got a very big network. We want her to share, obviously, and make us look good. So with her, I took extreme caution to explain to her that needing reading glasses is probably going to be necessary on some level. Now, not for everything. With the LAL, it does a fantastic job of expanding depth of focus. And if you do a little bit of a blend, you can make people very functional without glasses for most activities, but inevitably you're going to need reading glasses for some stuff. And that's just the reality of it. So for her, I think, John, you and I both talked to her on several occasions to make sure she understood that. I didn't want her to be unhappy. How do you bring them back? Do you do phone calls, Jenny, or how do you guys do that?
I do, and I also, like for that patient specifically, probably would have extended her treatments a little just to make sure everything was stable. I also find that hyperopes sometimes take a little bit and then they'll absorb more plus, after their second or third visit. So I want to make sure I'm not missing that. So sometimes I will do a treatment, I'll do a refraction, have them come back the following week. So there's like 2 weeks in between a treatment just to make sure. But I also, I let them know you can have them test it with some contacts before just to make sure that they understand what the amount of reading that they will have, and that their working distance will also have to be altered along with the amount of light that they're using. So I think setting realistic expectations and then hammering that in each time just as a gentle reminder so that they aren't harping on, I'm not able to see that tiny, tiny print on those bottles, just focusing more on the positive too. Like, are you able to see your phone? Can you see the computer? Those are the major things that we want to make sure that they're able to do on a day-to-day basis, as opposed to reading that small text in dim lighting.
Greg, what do you think? Any tips, strategies that you do for
we love RLE for hyperopia, and we go pretty young with it too. So, we've performed RLE on high hyperopes in their 20s and really had incredible results from that. And I would say that one of the things that we pay attention to, and not just the hyperopes, but all the patients, is what's their current method of optical correction? Because a glasses wearer that's a +8 has kind of a different life and a different experience than if they're wearing, contact lenses. And so trying to get an idea of like what their daily routine is used to for reading. Do they have that kind of edge glare off of a high plus spectacle lens, or is it contact lenses? So that kind of goes into how we're coaching the patients on what they should be expecting in terms of how the surgical outcome is going to compare to what they were used to. But I think, whether it be a lens replacement using an LAL for a hyperope or an ICL in a young myope, the point that, I think, John, you mentioned a little while ago is that, we do have so many options today to help people get out of glasses and contact lenses if that's what they wish to do. And it's really not just LASIK and PRK anymore, even though that's what most patients think. So one of the most important strategies or tips I would share is, when patients call the office and say like, hey, I want to come in and, get a consultation for LASIK, or oftentimes they'll even ask the question like, hey, how much is LASIK? The first response to that question, even at the level of the phone, is, that's a wonderful question. Have you actually been evaluated to find out if LASIK is the right procedure for you? There's several different procedures we offer. Some of them are laser based, some of them are lens based, and we'd really like to do an assessment of your eyes before we can make a recommendation around which of the different procedures we're going to do. And just floating that concept that it's more than just laser vision correction from the very first interaction with the practice, then continued through educational content that they get, via videos and apps to their phone. When they come in and meet with our staff, we're always talking about there's many different ways to correct vision, and it's not all just LASIK. And so getting that information about these lens refractive surgery options out there early and often can make a big difference in terms of patient adoption of the procedure that's best for them.
That's a great point. Can you talk about, so a short eyeball from somebody who's maybe some of our optometrists out there who aren't necessarily involved in refractive surgery, why is a short eyeball difficult to work with? Why are we more likely to miss?
Well, the surgery itself, I would say, can be slightly more technically challenging just because there's not as much room there. So like physically, when we're operating in the eye, there's a shallower amount of depth between in the anterior chamber. And so it's a little more crowded in terms of, doing the procedure that we need to do. And I think I would also say in terms of like predicting the power, maybe that's what you're getting, like hitting the target with the lens power. John, you may have a better answer than I do on this, but what I would say is likely is that, super high refractive errors, like super high hyperopia, is such less common than, typical refractive errors. And so some of the mathematical formulas that we have to predict the power of lens needed to implant in the eye are less sophisticated than a typical eye. So you're just based on bell curves and statistics, there's more variance in those super high ranges on the IOL side.
Greg, you're 100% accurate. That's exactly right. And one of the reasons why it is less accurate is not only are there fewer of them to like really be able to refine the algorithms. One of the main issues is that we've got a high-powered lens, just by definition, that you're putting in, plus 30, plus 32, whatever, and the effective lens position is less predictable. There are hyperopic eyes that have relatively deep anterior chambers, and there are hyperopic eyes that have relatively shallow anterior chambers. So the two aren't necessarily lockstep. And so the simple math on this is it's 7% of the IOL power for 1 millimeter of change. So 7% of a small number is not that much. 7% of a 30 diopter lens is enough where you can be off by a diopter and a half easily. And for no other reason than you can't really know where the lens is going to set. And so that's where the light adjustable lens comes in. It gives you that refractive capability to say, all right, no matter what, we're going to end up with a great outcome. Because I use a golfing analogy quite a bit, which is on a par 3, if you get the ball on the green, you've made a good shot, but you don't expect to get a hole in one. With the light adjustable lens, I'm going to get it on the green, but now I've got 3 putts, not 2. I've got 3 putts, and my target is now 5 inches across, and we're going to hit it every time. And so I say I'm using that euphemistically because, quite frankly, it's Jenny and Nick that are really doing the heavy lifting, making sure the patients get the great result that they do. So it is a team sport in that regard.
I'm better at this than I am at putting. Unfortunately, I wish I were a better putter, but I'm terrible at putting. So going back to the example I gave my 29-year-old patient, John. So with her, there was a couple of reasons why we didn't go with like a multifocal or an EDOF lens, mainly because we just didn't think it was going to give her the results that she wanted. Now she's a young girl. She's got big pupils, and she's in front of a stage. She's in front of studio lights all the time. That's her job. That's going to be miserable. I mean, if she's not tolerant of the dysphotopsies that naturally inherently exist with those lenses, that would be a problem. So we went with the LAL, and we went in with the idea that we would do a blend. We'd do one eye as plano, and then we'd probably end up somewhere at -1 or so from her non-dominant eye to get her the ability to see her phone when she's doing on-site reporting and doing, anchor desk work, so she could see her papers and definitely see the teleprompter without having any dysphotopsias. Now, the problem with her during the process was that we ended up, because she's got a really short eye, we ended up +2. And imagine if we didn't have an adjustable lens, it would have been disaster.
Yeah.
She was in tears. She came in and I had talked to her many times and we developed a pretty good rapport, but she was in tears, and I'm sitting there thinking like, holy cow, yeah, this is going to work, right? This is going to work. We're going to fix this. And she had brought her mom, and her mom was in from out of state because she was just not in a good mental spot. And I guess fast forward, I wouldn't share the story if it didn't end on a high note. She ended up wonderfully happy. I mean, she was plano in one eye, -1.25 in the other. She's fully functional. She wears reading glasses for real small stuff, but that's about it. She's one of our biggest advocates, and she did a wonderful testimonial for us that has hugely helped the practice. It's got thousands of views on YouTube. So that story, I think, is so indicative of what can go wrong in a short eyeball. I mean, we had a great surgery. It went beautifully, but she still ended up +2. And we had the highest lens that we have. Our Excite, the lens is produced up to 30 diopters. We use bilateral 30 diopter lenses. We couldn't go any higher. So yeah, it's a fun story I like to share.